Hi, everyone. I'm Donna McKay, the Executive Director of Physicians for Human Rights, PHR, and I'm really happy and grateful to be here today for this conversation with Dr. Michele Heisler and Dr. Tom Frieden. Since launching last March, PHR's webinar series on health and human rights implications of the COVID-19 pandemic has provided a forum for healthcare workers, scientists, and researchers, advocates, and voices from the front lines to examine and speak to the various impacts of the pandemic on public health systems, on healthcare workers, at-risk populations in the US and globally. And it has become a trusted source for information from experts as we try to all navigate through these challenging times. So thank you for joining us today for our 34th conversation in this series. Today, we're absolutely thrilled and honored to have Dr. Tom Frieden joining us. Dr. Frieden is a revolutionary global health leader in many regards and has transformed the sectors of public health, including HIV, tobacco control, and nutrition, to name just a few. Today, we're bringing you an intimate conversation on how the US administration can and should prioritize global COVID-19 response, as well as how the global community has to come together to what Dr. Richard Horton has called a syndemic, a combination of a highly infectious virus with the pandemic of non-communicable diseases that disproportionately afflict and affected by social and economic inequalities and structural injustices. So I'm very grateful to get us started and introduce PHR's medical director, Dr. Michele Heisler, to lead today's conversation. Aside from her critical role guiding PHR from a medical perspective, Dr. Heisler is a professor of internal medicine and of public health at the University of Michigan. She has built a career at the intersection of health and human rights, and her research has influenced national and international policies and programs. Through her pioneering work, she's built successful ways to leverage peer, family, and community support to improve the health of adults in low resource settings, elucidated health impacts of human rights violations, and successfully advocated for remedies. Dr. Heisler's expertise in evidence-based primary care interventions has made a significant impact in the prevention and management of chronic diseases, namely diabetes, which also heavily impacts populations disproportionately affected by COVID-19. So Michele, thank you for moderating today's conversation, and I turn it over to you.
Yes. Well, Dr. Frieden, it's a pleasure to welcome you. You've been, as Donna said, a pioneering thinker and leader on the most pressing public health challenges of our times. You've won too many awards and honors to list here, and you've published hundreds of influential scientific papers. You are now at the forefront of efforts to advance an effective global response to COVID-19 and to improve global health security for the future. In introducing you to our audience, I'd like to, many of whom I know you need no introduction, but I'd like to share a little bit about your remarkable history, crafting and leading public health initiatives. They're so expansive, and there are many lessons from them that I think are important to draw on to inform how we should respond to current challenges. So right after Dr. Frieden's infectious disease fellowship at Yale as an epidemic intelligence service officer at the CDC in New York, he gained invaluable experience as a frontline worker monitoring and surveilling disease conditions. From there, he headed up the Bureau of Tuberculosis Control at the New York City Department of Health, and that happened to coincide with the largest outbreak of multi-drug resistance TB ever in this country. To rein it in and keep it from happening again, he helped spearhead a program that is now a model for TB control in this country and the world. From 1996 to 2002, he worked in India for the World Health Organization, helping India's national and local governments implement a highly effective TB control program. He then headed back to New York City to head the New York City Health Department as health commissioner. He was there until 2009. There, he continued to pioneer what he has called interventional epidemiology, systematically gathering and using data to drive progress. He spearheaded cutting-edge programs to address two still ongoing pandemics that we cannot forget: tobacco use and cardiovascular disease. As a diabetes translational research also, diabetes is a cardiovascular disease equivalent. So also addressing the full range of things that smoking and food and environment can affect. He banned smoking in workplaces, restaurants, and bars, and initially eliminated trans fats in our food supply in New York, and that within 10 years led to the FDA banning it throughout the US. Since 2017, I've skipped over the CDC. So from 2009 to 2017, as director of the US Centers for Disease Control, he helped guide US and global responses to the Ebola and Zika epidemics, the global H1N1 swine flu pandemic. He also, and I think this is important to emphasize, he set up the first ever nationwide data system that monitored the state of racial and ethnic health disparities, using that to identify areas that advocacy, programs, and community support should target. Since 2001, Dr. Frieden has served as president and CEO of Resolve to Save Lives, an initiative of the global health organization Vital Strategies. There, he is continuing to test and scale up innovative strategies to prevent cardiovascular disease and infectious epidemics. He also continues to have an important platform in his role as Senior Fellow for Global Health at the Council on Foreign Relations, the Council on Foreign Relations. Welcome, Dr. Frieden. I'd like to start with I partly gave that history because I'd like to start with a broad question to help frame our more targeted discussion on crucial next steps and priorities. As I briefly sketched, you have led responses to both infectious and non-communicable disease epidemics and pandemics, from TB in New York City and India to smoking and food-related illnesses like hypertension and diabetes. As we move to the next stage in combating COVID-19 and beyond, what are some of the most important lessons? Again, thinking broadly, what are some, from these multiple, but in some ways, many similar threads? So talk a little bit about what you feel are some of the lessons about effective responses, both in terms of immediate short-term steps, as well as longer-term necessary programs and policies.
Well, first off, thanks very much for inviting me. It's delightful to be here. And I've had long respect for the work of Physicians for Human Rights and many of your current and members and founders and others. So it's great to have the chance to chat with you. The way I think about what's really needed for public health progress is with the simple mnemonic of TOP: technical, operational, and political. You need to touch all of those things and get them right. Technically, you need to have rigor. You need to know that if you're recommending that 5 things are done, doing those 5 things is going to achieve the result that you want to achieve. Operational is about management, and public health is often really a management problem. That means in the case of an outbreak, using an incident management system. One of the things that was so stunning about the failure of the prior administration to respond competently to the COVID pandemic was the complete absence of organization. In an unguarded moment, I was accurately quoted by a Washington Post reporter as saying, "It's mind-boggling, actually, the degree of disorganization within the administration." And up until January 20th, it was never clear who was in charge, who was speaking for what. It was just a complete lack of organization, which is, as we'll get into, it's encouraging to see the opposite of that now. So technical, operational, and political. Because public health decisions, as we all know, are political decisions. And a failure to make a decision or an investment or an intervention is also a political decision. So I think the key about infectious and non-infectious is to get those 3 things right, to make sure that you're technically rigorous, that you manage well, and that you manage the politics and the context well also.
And in a recent report, you talked about some of the countries that had successful responses. And again, I refer our audience to that really enlightening report. It did not depend on wealth or resources necessarily, but did indeed engage and involve all of those three components of TOP, technical, operational, and political. And of note, only American Samoa made your top list of successful case studies. So I do urge our audience to read that report. So you said that you are encouraged, that it is encouraging. Many of us have greeted the Biden administration's commitment to science-driven pandemic response, focus on organization, on a coordinated national plan. And many of us are encouraged by these initial actions. So tell us a little bit more. What's your assessment, thinking of some of these plans and proposed strategies, both in the US and globally? How are they doing so far? But what are some of the key deficiencies that you, as an outsider now, you can speak, as you also are trying to advocate for, what's going well, and what maybe needs to be stepped up a little bit now?
Right. So I think I'm really encouraged by the administration. I got to work very closely with Ron Klain, who's currently the chief of staff, and he's terrific. He's really, really smart, really competent, really strategic. I worked with him quite intensely for a year plus in the Ebola response, and I just found him to be remarkable. So I literally have slept easier knowing that he's in a critical position. Jeff Zients is kind of in the Ron Klain mold of a Mr. Fix-It type. That's really important on the operational side. Again, what you're seeing from the incoming administration, the current administration, is clear organization with a plan. Plan beats no plan. On January 21st, they released a 198-page plan that's really good. Not only did they have a plan, but it's a good plan. And they have a clear organization, a clear structure. They're basing on science, and they're communicating very effectively. So this is really day to night compared to how things were going before. Now, that said, this is a really, really tough pandemic and a really tough vaccination campaign. This will be the most complicated vaccination campaign in United States history. So it's not going to be simple or quick. I think one issue that the administration is very focused on appropriately is racial inequality. Black people in the US are 2 or 3 times more likely to die from COVID, and yet only half as likely to have been vaccinated. That's unacceptable. And it's a reflection of the failure of the prior administration to undertake the kind of meticulous planning that's required to run a campaign that involves communities, recognizes community leadership, identifies the messages and messengers that are important for and effective to reach those communities. And if you don't do that, you're not going to get the kind of results that you should be getting. So one issue is racial and economic outreach, and there are ways to manage this better. One county that we work with, for example, is giving slots for vaccination by zip code. And sadly, the zip code in the US is far more predictive of your health status than your genetic code, because we are so segregated by economic class in the US. But by doing that, they're basically saying, we're going to fill up this zip code before people from the Tonier zip code can get their next batch of 100. You also need outreach and pop-up clinics in different places, and to identify every strength and resource in the community. One thing that I've found over the years of doing public health programs is that every community has strengths. And by identifying and enlisting those strengths, you can do better in terms of reaching people faster, higher quality, more acceptance. It's also true that we have weaknesses. And one of our weaknesses has been the partisanship and the lack of focus on science and fact that has plagued the US increasingly in recent years, and that really has been the Achilles heel of this country's response to COVID. And I think the current administration is going a long way to try to fix that. On the issue of ethics, and Marine Boussanier talked about this last week in your session, this is very important. And I think we have to be eyes wide open here. It is ethically unacceptable for healthy people in rich countries to be getting vaccinated or treated with effective drugs before people who could die, or healthcare workers, nurses, doctors, people over the age of 65 in poorer countries that don't have vaccine access. That's ethically unacceptable. It's also politically untenable to think that there's going to be a very different response, even though rationally we know that uncontrolled spread of COVID anywhere risks control of COVID everywhere because of the emergence of mutant or variant strains of the virus that may be able to evade either our natural immunity or vaccine-induced immunity. I think the only way through that very difficult dilemma is to ramp up global manufacturing in a sustainable way, and to think about how we can increase the production of life-saving diagnostics, therapeutics, and vaccines in regions around the world as a global public good, ensuring quality and low cost. I like to go back to something that most people would think is really outdated. In the early 1900s, the New York City Health Department was one of the leading scientific institutions in the world, and in fact produced a significant proportion of the diphtheria antitoxin, tetanus toxoid, and other biologicals that were needed by health providers and health departments around the country. In fact, it was such a leader that during the 1918 pandemic, all eyes turned to the New York City Health Department to try to come up with a vaccine. Unfortunately, viruses hadn't been discovered yet, and they weren't able to succeed. Letterly Laboratories, a large pharma company, was started by Dr. Letterly, who had learned how to create these products by being assistant commissioner of the New York City Health Department. So I don't anticipate that public production of highly complex products will become a dominant mode in the future, but I do think that these are global public goods, and we need a way to figure out how to ramp up manufacturing in a way that is sustainable, high quality, and addresses that terrible dilemma of equity versus politics.
Yes, and there have been many proposals of thinking, how do we ramp up production? We at PHR have joined the People's Vaccine Campaign, arguing, as just recently, Dr. Fauci also just recently argued this, that, maybe, as was the case with polio, with Jonas Salk and Sabine, they said, this is such a crisis. This is such a global health catastrophe that this may be a case where we need to think about intellectual property rights in order to allow, as ultimately happened in HIV, it was not, that was a long process, that manufacturers in Brazil and India. So again, that's a very controversial issue. It's a very, some of the companies did get, Moderna was funded by the government. Pfizer did not take government money. Talk a little bit about that. I know it's a little bit of a fraught issue, but how do we ramp up manufacturing?
Yeah, it's not simple. These are not going to be easy things to address because it's not just about IP. It's also about the ability of entities to actually produce products, and that may not be so simple. There are hundreds or thousands of tips in the manufacturing. So it's going to have to be a very intense partnership, and there are different models. If you started from scratch, you'd be years away. You also have to make sure that whatever gets made is not a second-class product, that it meets all of the regulatory requirements. You also have to think about what's going to happen between emergencies. How are you going to keep that capacity up and running? And I'm honestly not an expert in this area, but I do think there should be a solution. I think the US should help fund it. We have, as Marine Boussanier has taught me, we have march-in rights for many of the products, and there's a strong public rationale for increasing production. So I think this is an area that needs further progress. I think we have to recognize that there may be some solutions that sound simpler than they are, but even though it's hard, we do have to make progress doing it.
Yes. And I want to, your last answer was so rich. I now want to focus a little bit on what you said about the critical importance of equity. I think this is also an area where, as I think about the need for interventional epidemiology, reading about, for example, your old institutions, a dear institution to all of us who live in New York, the New York City Health Department, and there has been criticism about stumbles in achieving that equity. Things like everything's online. There should be good data about communities where it's not going to work, requiring that people sign up online. There's been reports of, even if you have a zip code based approach, white people, wealthy people, standing in line, going to the sites in those zip codes, things that do suggest that we have a critical rupture between the data we need. So what is data about the populations? When you were a commissioner in New York, you started the first community surveys, just so you could look at things like, if you're going to expand access, how do you do it? It's probably not through online portals. It may not be in these big mass vaccination sites for people that lack good transportation. Talk a little bit, and this is getting a little bit into the future, but it's heartening, as you said, that there is now a health equity task force with a remarkable woman, Marcella Nunes-Smith, at the head of it. There is efforts to really integrate a concern with equity. But there's data deficiencies, clearly. We now are thinking of a national coordinated response. This ties into a question, which if you want to also address here too, we have underfunded, fragmented healthcare systems, not underfunded healthcare systems, but fragmented healthcare systems, and really horribly underfunded, undersupported local healthcare departments that really need to do this reaching out to, as you said, trusted messengers, actively involving community organizations, which is really the only way to generate trust, participation, as well as better strategies for dissemination. So talk a little bit about that. I know these are key, these are close to your heart, and you've worked in various ways to address this.
So first, I just want to mention an effort that we're honored to be part of called Choose Healthy Life. It's a partnership with the United Way of New York and 10 cities around the country, with leadership from Black religious leaders, including Reverend Calvin Butts, Reverend Al Sharpton, Reverend now Senator Warnock, and others. And the goal is to have community-led interventions to reach out. And these should include pop-up vaccination centers, but we need to identify the messengers that work, that are most effective for each community, and the messages that work best. If you look at global public health programs for best practices, the creation of a micro plan is really where it's at. And this is what we do with measles and polio and other things. And it literally means thinking about every single building and every single block and saying, how are we going to reach the people there? Who's going to vaccinate, when and where and how? And then having continuous learning from that, which is crucially important. And that's why we released earlier this week a set of core indicators that we believe every state should have in a consistent way on vaccination. My group, Resolve to Save Lives, assessed the websites of every state, DC and Columbia. And what we found was a lot of hard work, but kind of a Tower of Babel. You can't compare one state to another. The same word means different things when different states use it. And you're not getting really crucial information, such as the proportion of the population vaccinated by race ethnicity. I think only North Dakota actually had that information by race ethnicity over time. So you can see, are we getting better? Are we not? And what gets measured can get managed. So one crucial aspect is having good data to manage that. Another is engaging with communities. And as a New Yorker, New York City isn't one community. It's not 5 boroughs. It's not even 41 health districts. It's literally hundreds of micro communities, some defined by, or not so micro communities, some defined by geography, some by demographics. And you have to, in a micro plan, you think of how to reach out to every one of those communities in a way that's acceptable to them. And this is something that shouldn't just start in an emergency. For example, when we were doing emergency planning when I was commissioner here, we tried to establish pre-existing relationships with as many of the communities as possible to identify who are the community leaders, who are the opinion leaders, who's respected, what are the media channels to reach them, what are the social settings. And that becomes doubly difficult in the context of COVID, where we're not in contact with one another, and particularly difficult for this vaccination campaign, which is the most complicated this country has ever done. 2 doses, multiple vaccines, very complex storage requirements, a lot of controversy, initially a lot of politicization, a lot of distrust. So this is going to be hard, and it's going to take us working smart and working together.
Wonderful. And I do, we have a question from the audience that's so apropos of this discussion that I'm going to ask this specific question. I do think you addressed this in your answer, but the question is, can Dr. Frieden speak to the intersectional approach to end racism and other forms of oppression in public health? I think you spoke to this, but it's a little bit more targeted on that particular approach to this intersectional approach of addressing these issues.
Well, I think we have to work, as Martin Luther King Jr. said, with the fierce urgency of now. And we have to make as much progress as quickly as we can, working strategically. And some of the changes in the Biden administration's proposal for the $1.9 trillion relief package could have a major benefit on promoting racial equity in the US. Things like the child tax credit, the earned income tax credit are crucially important. We recognize in health that what we do in health care is not the primary determinant of health. Mm-hmm. And what we do in the health sector may also not be the primary determinant of health. I remember once I was visiting a middle school in New York City, in the South Bronx. And I had an interchange with the kids. And I asked, what one thing can you do to have a longer, healthier life? And I was looking for an answer like, don't smoke, don't use drugs. And one 8th grade girl raised her hand and she said, get a college education. And I was just blown away because that was a much better answer. It was factually more accurate than any answer that I had hoped to get or that I had thought of myself. So I think whether it's agricultural policy or educational policy or transportation policy, social services, or broad health policies, all of these are crucially important to improve health. I do want to talk for a minute about hypertension, because sometimes I fear that progressive forces can be very general, and waving the flag is great, but doing things that get people to concretely live longer, healthier lives is also great. And if you look at high blood pressure, it is probably the most neglected problem in the world. Globally, it kills 10 million people a year, more than all infectious diseases combined. In the US, hypertension is a leading killer. And in fact, hypertension is the leading cause of the difference in the life expectancy of Black people versus white people in America. 1 out of 4 Black adults has uncontrolled hypertension, 1 out of 4. That compares with the still way too high, but much lower rate of 1 out of 7 white adults. And addressing that is going to require at least 2 things that we know work and can be scaled. One of them is the reduction of sodium in our foods. We eat way too much food. And Mike Jacobson just published a great book, Salt Wars. I recommend it to you. We are basically awash in a diet that has 2 or 3 times more sodium than we need. And because of that, our taste buds have gotten numbed to the amount of sodium we're getting. And it's everywhere. It's in breakfast cereals. It's in bread. It's in pizza. It's in things that we never imagined had much salt, like ketchup. In other countries, including the UK, they were able to substantially reduce sodium. You can reduce it by 20% in almost any product without anyone noticing. And then if you gradually reduce it another 20 to 30%, people will adapt to that. Now, sodium reduction stalled for decades, but I'm hopeful that this administration will not only stop COVID, but also start progress reducing sodium consumption in the US, because you can save billions of dollars in healthcare costs, as well as hundreds of thousands or millions of lives, and you can have a major impact reducing not just overall mortality, but the black-white difference in cardiovascular mortality and overall mortality. The second component is effective treatment of hypertension. And I have to be careful here because I might take the rest of our time discussing this. But I want to emphasize that if you think big picture, the point of healthcare, above all else, should be to preserve life, to reduce illness, injury, disability, and death. And I do think there's primacy for reducing premature death. And we looked at this. The single thing you could do that would reduce deaths the most in the US healthcare system would be to control hypertension. And it's not expensive. It's particularly important for people who have diabetes, for whom hypertension is the most likely thing to kill them young and early and contribute to amputations and loss of kidney function. And it can be done with low-cost medications that are easy to take, don't have adverse events, are safe, and work. If you look at a healthcare system like Kaiser Permanente, they went from 40% control to 90% control, including in their Medicaid population, including in African Americans. It can be done. It must be done. If you look at pilot programs like a barbershop-based program, you've seen dramatic improvements in control rates. So I look at the US healthcare system. We're spending way more per capita than any other country. And look at the single indicator, the single most important indicator of the impact of healthcare, which is hypertension control rates. In the US, we made a big effort under Million Hearts to improve this. And we went up to 54% control and then down to 44% control, despite this effort. So we have to change the way we do healthcare in the US. And that means making primary care the center of our system, moving to a capitated system, reducing the kind of bureaucracy and paperwork that torture primary care doctors, increasing payments to primary care, because there's no mystery why we have a shortage of primary care doctors. You've never heard of a shortage of anesthesiologists, radiologists, or cardiac surgeons, right? And there's a reason for that. And it's not because those fields are inherently more attractive than primary care. It's because they pay more. So I think we have to really, really change the way we orient our healthcare system to focus on primary care. And that's one example of how we have to address the problem of racial, ethnic, and class inequality, not just with specific individual programs, but also with a general approach through multiple sectors and focusing on the importance of broad social and cultural change.
So yeah, again, so critically important. You know, understandably, we're all focusing on COVID-19 now, but as you just said beautifully, this is superimposed on long-standing pandemics of hypertension and other conditions that do predispose people to COVID itself, or to infection and death, but also are also a result of our systems of structural racism and structural inequalities. Right now, the world is paying attention to public health. And again, there are many people that have tuned into this conversation between us today, thinking, oh, we have to focus on COVID-19. And so I'm glad this message is coming out, because they are also interlinked. But now is a moment when there's a lot of attention to public health, a lot of awareness of the deficiencies of both our healthcare systems, as you said, in the US, a lack of attention to primary care, a lack of attention to the necessary public health infrastructure. So what are some of your ideas about how we might leverage the incredible collaborations and networks that have emerged to fight COVID-19 to also tackle other conditions that you've devoted your life to fighting? And then, talk a little bit about this. And I do want to say there's a couple of questions that, knowing that you know a lot about comparative systems in other countries, there are some questions about Cuba, as what if there are good elements from countries like Cuba that have really placed an emphasis on public health, preventive care. So I wanted to weave that in, because there have been a couple of questions from our audience.
Sure. Maybe let me take that first.
Yeah.
At Resolve to Save Lives, we focus on hypertension treatment around the world. And as we've done that, we've looked more and more at primary healthcare systems. And what's really striking is that if you look at low and middle income countries for good primary healthcare systems, you think of Cuba, Costa Rica, Thailand, and then you really struggle. Sri Lanka, maybe. And I'm sure there are others, but not many others. So it's not just a weakness of healthcare systems of the US and other rich countries. There are countries like the UK and France that have good primary care systems. So one of the things that's quite striking about these countries is that there is a consensus about a right to healthcare. It's not in doubt, no more than it's in doubt in the US that you should be entitled to a K through 12 education. Now that should be much better and more equitable, but nobody doubts that you're entitled to a K through 12 education. In Thailand, through many different governments, no one doubts that everyone has a right to primary care. So one thing is the political will. In the United Kingdom, whether right or left, all governments recognize the National Health Service as essentially sacrosanct. A second crucial component of effective systems is a team-based approach. There was a question about intersectorality. There's also interprofessional work where we need to be much more effective. I started my career as a tuberculosis doctor, and I had been internal medicine resident at Columbia, an infectious disease fellow at Yale. I had written my master's thesis on tuberculosis, and I volunteered for the tuberculosis clinic just a few blocks away from where I live in Brooklyn. And in that clinic, there was an older nurse who was from Jamaica, and she would very sweetly come in and say, "Dr. Frieden, are you sure you don't want to," actually she's from Barbados, excuse me. "Are you sure you don't want to prescribe 1,500 milligrams of pyrazinamide for this patient?" And she was of course right, because when we go to medical school, they kind of take the neurons out of our brains that allow us to follow protocols. And nurses give better quality care for many, many conditions. If I had to be anticoagulated with Coumadin, I would want to be managed by a nurse, nobody else. And the same can be true for a large range of health conditions. So political commitment, team-based approach to care, and an obsession with denominators. The best healthcare systems I've seen around the world in progressive countries, you walk into a health post or a health center in a rural area and you ask, what do you do here? And they say, oh, we have 17 programs. And they discuss for you this is our TB program. This is our reproductive health program. This is our malaria program. This is our diabetes or deworming or anemia. And for each of them, they have a technical package. And often they'll have a wall chart with how they're doing on that program. There's been a lot of sterile debate in public health, between vertical and horizontal programs. It's really important that there are specialized programs, whether that's HIV or tuberculosis or hypertension or diabetes, but it's very important it's delivered in the community in an integrated fashion. So I think those are some of the lessons from some of the best systems in the world. Cuba, I just wish they had the resources to provide antihypertensive drugs to everyone who needs them, because they could have the highest hypertension control rate in the world if they just had the money to buy the drugs or make the drugs as they do there themselves.
Well, I do refer our audience. I know you all are developing really terrific digital tools to guide decision-making around blood pressure medications. And I will not initiate a conversation on the poly pill, although at another point I would be fascinated to have that discussion with you as a way of addressing some of these issues and resource in less resourced countries. You talked about team-based care as a better model. I'm a primary care physician. I will say I'm a primary care physician at the VA. We have spectacular team-based care. I wouldn't practice without it, without the person that is the LPN, the RN, the clinical pharmacist. We are all the providers for our patients. And that's been another issue that I do want to target. Many people on this call today, many of our constituents are healthcare workers. We at Physicians for Human Rights have really been focusing on this issue of the health concerns, the human rights concerns of healthcare workers throughout the world. In today's New York Times, there's yet another article on the high numbers of infections, deaths, psychological trauma among healthcare workers. You also at Resolve to Save Lives published a report in mid-January on what we need to do to protect healthcare workers. In that report, you discussed the paucity of data, and I think that's a running theme through many of our most pressing issues. And you also talked about ways that countries need to strengthen health systems, which we've touched on just now, and better support healthcare workers. This is a crisis. We're in the midst of this crisis. What are the immediate steps that need to be taken toward these aims of this very depleted, threatened healthcare force, not just in our country, but throughout the world?
Right. So I think the first thing to say is that the level of infection in healthcare workers is just unacceptable. And it's not just COVID. COVID continues a really long and unacceptable history of the risks to healthcare workers being far too high. Amanda McClelland, who runs our emergencies program and is a nurse, and I wrote an op-ed on this for CNN, and we cite the report that we just released with 17 other organizations that call on the world to do much better. In the US alone, the CDC estimates that at least 70,000 people each year are killed by infections contracted in healthcare facilities. 70,000 people are killed, not healthcare workers. 70,000 people a year are killed by infections picked up in healthcare facilities. And healthcare workers all too often get tuberculosis or other conditions through their work. When we look around the world, something like a third of healthcare centers don't have running water. And you can't really do decent infection control without water. So that's something that the global donor and multilateral community has to address. We also need tracking systems so that we can know what's happening in terms of healthcare worker infections and be transparent about it. And then we need to build the capacity of countries to have infection control practitioners in each facility who are empowered to get stuff done and supported by the leadership of that facility. Without that, you don't see much progress. We have seen a lot of progress in the US in the past 5 or 10 years, making healthcare safer. But around the world, the risk of infection to healthcare workers and to patients is far, far too high. And of course, as you mentioned at the outset, this isn't just about infections. Attacks on healthcare workers are just up in a way that I think is unprecedented. And it continues as an unacceptable trend that has to be reversed. The Red Cross used to be a symbol not to attack. Now it's becoming a bullseye, and that's unacceptable.
Yes, absolutely. And that is an issue that we at Physicians for Human Rights have really focused on, as well as the right for freedom of speech of healthcare workers. We've been tracking reprisals, intimidation of healthcare workers who have tried to go through the system. They've tried to go through proper channels and have felt that it was their professional duty to speak out about safety lapses and have suffered reprisals. So another critical issue. I can't resist. I have to ask you about the CDC. Again, under your leadership and throughout almost all of its history, the CDC has been internationally respected and trusted, and this has been shaken in recent years. One really heartbreaking example that I do want to note that we at PHR have been grappling with has been its the fact that the prior administration overrode medical and scientific experts to issue the CDC directive under Title 42 of the Public Health Safety Act in March 2020. And that directive used COVID-19 as the justification to authorize shutting the US-Mexico border just to asylum seekers, not to other classes of travelers. So, and again, completely overrode the expertise and the views of CDC experts. That's just one of many examples. It's very heartening, as you've noted in other things about the new administration, that the new CDC director, Dr. Rochelle Walensky, she's ordered a comprehensive review of all CDC guidance on COVID-19. That's a critically important first step. But outline for us what you think are some of the next steps to rebuild trust in the CDC and, frankly, to rebuild the CDC.
Well, first off, I think it's important to make clear that despite the problems that you outline, thousands and thousands of staff at CDC continue to do really good, important work over the past year. They just weren't allowed to talk about it. So part of what has to be done is the good work that's getting done needs to be shared with the public. And one of the main issues is surveillance data. There's been steady improvement over the past 2 weeks in what's available from the CDC site. There needs to be further improvement. We should be able to get the latest information on the pandemic from the CDC website. It's not quite there yet, but I think it will be within another few weeks. But more broadly, there needs to be communication. The principles of risk communication, which the CDC established, were be first, be right, be credible, be empathetic, and give people practical, concrete things they can do to protect themselves, their families, and their communities. You couldn't possibly have violated those principles more than the prior administration did. And I'm encouraged to see the degree to which the current administration is addressing them. Now, they've begun having regular media briefings. That's really important so that the experts from CDC can speak directly with the American public. Having been in that situation on the podium many times, I can tell you that a lot of things happen. First off, you can get your message across. Second, you can discover that what you thought you were saying clearly isn't clear, even to highly experienced reporters who are then asking you about something you said. So you can clarify how you say it. Third, often health reporters will ask a good question and raise an issue that allows you to explain it further. And sometimes they'll even ask you a question that you don't know the answer to. And that tells you that you've got to go back and strengthen it. So that communication is a two-way communication. It's almost like peer review in the scientific world. If you're not getting peer review, you're not upping your game. And CDC's inability to speak with or hear directly from reporters and the public for the last year has meant that some things haven't gone as well as they should. There are also things that clearly went wrong, particularly rollout of the test in February. And that needs to be looked at carefully. There were a lot of attempts by the prior administration to blame the CDC for everything. But if you look at the test issue, there were essentially three things that need to happen. The CDC needed to make a test for public health labs, and they stumbled. They lost a few weeks in that process, and they were important weeks. But the second was the FDA needed to allow private hospital labs to develop their own tests, and they didn't. Not until March did they make that process easy. And third, HHS needed to convene the manufacturers as South Korea did in early January and said, get together and do this. And they didn't do that till March, and they really didn't do it in a sensible way all along. We've been paying a lot of money for tests that are coming back in such a long time period that they have very little value. So I think the CDC will regain the trust because there's a lot of great work going on there. It's not going to happen overnight. In fact, the CDC website has been visited more than 2 billion times on COVID. So people are still voting with their clicks and listening to what CDC says, but it does have some recovery to go through.
Yes. So I want to weave in, I've been trying to weave in some of the audience's questions, and I apologize. I do have to say, we have Joan Bowers wanted to really thank you for acknowledging and promoting the importance of interprofessional teamwork across nurses, physicians, pharmacists, and others. A couple of questions have come in about, as you had said, we have to build from the ground up. You currently are focusing on some very targeted ways that we need to improve early global response. We need to have new solutions in terms of having more funding. And again, those are specific solutions. But ultimately, this has to be embedded in a robust healthcare system. As you said, a coordinated, and a fundamental problem that we haven't touched on directly is the fact that millions of people don't have health insurance now. Millions of people actually have no access to healthcare unless they pay out of pocket, even with the tremendous gains in health insurance coverage that came with the ACA, the Accountable Care Act. So a couple of people have asked, this isn't an issue that this can be just you, Tom Frieden. I don't think it's something that your current organization has taken a stand on. But what about Medicare for All? Certainly the current administration is going to lower the age of Medicare to 60 and older, which is a step towards coverage for a critical age, 60 to 65, when many people do have a lot of comorbidities. There's other measures being taken. This isn't off the record, but this is you as Tom Frieden. Should we be moving towards Medicare for All?
Well, I think, it really comes down to what can be achieved. And if you were to sit down and come up with a rational healthcare system, you could design one that costs a lot less than our healthcare system today, that gives a lot better care, results in longer healthy life expectancy for Americans, and significantly reduces some of the inequalities in health that we have. Mm-hmm. But to get to there from where we are now requires going through the buzzsaw of Congress. And frankly, as we saw with the Affordable Care Act, and if you read President Obama's memoir about what it took to get what was there through, is very painful. Now, what's possible now? That's really up to the administration and Congress to figure out. But what you want to have is the best possible healthcare for as many people as possible. I think we have to look not just at coverage, which is crucially important, and maybe there are ways to deal with states that have not expanded Medicaid because of a Supreme Court decision that made that problem. But we also have to look at the quality of care. Most people on Medicare have supplemental policies, and it's not popular, but I will say frankly that I'm troubled by Medicare Advantage plans. Medicare Advantage got sold to Congress because it was more efficient. The private sector is more efficient. It would do it and save money. All right, prove it. So now, many years later, Medicare Advantage plans get 105% what fee-for-service Medicare gets paid. Now, I don't know what your definition of more efficient is, but paying 5% more is not my definition of more efficient. Many of those plans provide vision and dental, which is certainly needed. That is something that could be provided in Medicare. But I really want to go back to the issue of hypertension control, because we are losing many, many lives because we're not controlling hypertension well. And if we can't provide quality service, then however much we increase coverage, we're still going to have a big gap between how healthy we could be and how healthy we are, what our healthcare system could achieve and what it does achieve.
And again, I want to just echo what you said, is that healthcare is a small percentage of what determines wellness and longevity. We all need, in all these areas, have to be changing the environment, addressing the social determinants of health, the communities in which we live, play, work, worship. I realize that it's 3:27. I have so many more questions. I think I covered some, but not all of the audience's questions. Dr. Frieden, thank you so very much for this really far-ranging, really important discussion. And again, I have to say, on behalf of Physicians for Human Rights, we are very heartened that many of the issues that you have done such spectacular work advocating, we're working on measures to ensure a fair and equitable distribution of vaccines, efforts to increase the global supply, as well as efforts to protect healthcare workers and to address communities, whether in conflict areas, marginalized and oppressed groups in our country and elsewhere that have suffered injustice and human rights violations that also have to be addressed to promote health. I want to say that in the coming weeks, we at Physicians for Human Rights will be advocating on a national and international level, as I said, to prioritize frontline healthcare workers, prioritize marginalized and historically disadvantaged communities, and to ensure an equitable global distribution of vaccines. So again, eager to collaborate with you on these efforts, with those in the audience. And I just wish you Godspeed in all your incredible work. And thank you for taking an hour to talk with us today.
Thank you so much for all that you do at the organization. I've been delighted to be with you. We didn't get to the questions on vaccine hesitance, so I would just say it's really important to listen to what people are saying and what their concerns are, and then to try to address them and to have patience. A softer approach often works better with vaccine hesitancy, and convenience usually wins out over hesitancy. So making it easy to get vaccination is important. There's a movable middle that is a lot of people. There are some people who are really dug in and they're not going to change. But thank you all very much. It's been a delightful hour, and all the best to you.